Good morning, everyone. Thank you for tuning in to Pediatric Grand Round this morning. I have the pleasure of introducing our absolutely dynamite team of speakers today. It is Dr. Erin Calhoun, Dr. Amy Hansen, Dr. Tara Kopp, Dr. Megan Lanowicz, and Dr. Carrie Marks. Dr. Calhoun is a tenured professor in the Pediatric Department at the University of Louisville and an attending physician in the Just for Kids Critical Care Center at Norton Children's Hospital. He is the Associate Chief of Pediatric Critical Care Medicine and is the Senior Advisor of the Simulation for Pediatric Assessment, Resuscitation, and Communication, or SPARC program at Norton Children's Hospital. He's a member of the Board of Directors for the Society for Simulation in Healthcare and co-chairs the International Network for Simulation-Based Pediatric Innovation, Research, and Education. Dr. Calhoun also serves as an associate editor for Simulation in Healthcare, the primary journal in the field, and is a fellow in the SSH Fellows Academy. Dr. Hansen is an associate professor in the Department of Pediatrics at U of L. Dr. Hansen currently serves as the director of the SPARC simulation program for Norton Children's Hospital, and she focuses on improving patient safety using simulation to optimize interprofessional team dynamics and procedural performance, identify and correct safety threats, and enhance system operations and efficiencies. Dr. Hansen practices as a pediatric emergency medicine physician for Norton Children's Hospital here in Louisville. Dr. Tara Kopp completed her pediatric emergency medicine fellowship at Cincinnati Children's Hospital in 2019, and then joined the pediatric emergency department of Norton Children's Hospital in Louisville, where she practices as an attending physician. She is an assistant professor in the Department of Pediatrics at U of L, and Dr. Kopp is dedicated to simulation and graduate medical education through service of the SPARC Pediatric Emergency Medicine Node Leader and co-director of the Pediatric Resident Procedure Rotation. Dr. Megan Lanowicz received her MD from Vanderbilt University in 2004, subsequently completed a pediatric residency in emergency medicine at the University of Michigan, and fellowship in pediatric emergency medicine at the University of Arkansas for Medical Sciences. She is now an associate professor of pediatric emergency medicine. Her primary academic interests include simulation and trauma team management. She also serves as the assistant director of operations for the SPARC simulation program and heads the pediatric simulation curriculum development for the U of L emergency medicine residents, and is deeply involved in the Norton Children's Hospital trauma program, leading the trauma QI process for the emergency department here. And last but certainly not least is Dr. Carrie Marks, who joined Norton Children's Neonatology in 2015 after completing a neonatal perinatal medicine fellowship at the University of Vermont. Dr. Marks' overarching goal for the NICU is to provide high-quality, evidence-based medicine for every infant. Her research interests include postpartum depression, implicit bias and inequality among medical professionals, and simulation-based medical education. Dr. Marks is active in the neonatal medical community, both as an author for the Cochrane Neonatal Group and the leader of the Norton Children's Neonatal Neurology Initiative. So I will hand things over to our speakers this morning and share their presentation.
Hello. Welcome to Grand Rounds. This is Dr. Amy Hansen. Thank you for being here as we discuss transformative simulation, enhancing teamwork, safety, and system operations. Please comment if for some reason you can't see or hear appropriately. Since we're presenting in a virtual platform, we've all convened in the same room today, but you can't see us. And so I've included sort of a lineup of all the people that are going to be presenting for you today in the order in which you're going to hear from them. There are also a myriad of other colleagues that we work closely with in the Spark simulation program, many of which were directly involved in the work we're going to be presenting, and so many others doing vitally important work in other arenas. I do want to thank my incredibly valuable colleagues that I've had the pleasure of working alongside, learning from, and collaborating with over the years: Dr. Lanowitz, Dr. Kopp, Dr. Marks, and Dr. Calhoun. I also wanted to briefly thank all the professionals that have participated in our healthcare simulation program with Spark, and for allowing me to photograph their good work and include some of their images presented in this talk. In terms of disclosures, Dr. Calhoun has a few disclosures listed there on the left. The rest of us do not. Our objectives today are to expand simulation-based exercises to encompass more modalities and applications than just traditional mock codes. We're also going to discuss how simulation can be used to address safety issues and improve patient care in the hospital and beyond, and understand the current trends and developments within the global simulation community. What we're discussing today are really localized uses of these concepts, but our real intention is to help those listening to understand how you could really apply these strategies in your own units or with your own division or with a larger audience, or even incorporate small aspects of simulation into your practice to help you achieve your own goals. During this talk, if you happen to think of novel ways you have or could apply simulation in your own department or division, please comment live or in the chat so we can follow up with you about that. The first question we asked ourselves was, how can we prepare people for deep decision-making in complex, stressful situations? We originally thought of this in the form of medical education, and we've long understood that even using games like Dungeons and Dragons or Command and Conquer or playing video games, we've learned that critical thinking and problem-solving strategies can really be wrapped up in a fun exercise, and the skills can actually be cultivated and honed and are in many cases transferable to other settings. We've learned a lot from the airline and aerospace industries that many of the same threats of distraction or assumptions, communication failures that threaten their safety had very real healthcare applications. In the year 2000, the Institute of Medicine put out this well-known report, To Err is Human. And in it, they found that 98,000 deaths per year in the US were found to be due to medical errors. An updated report in 2014 found that medical errors were the third leading cause of death in the United States. This obviously stands in pretty stark contrast to the medical oath we all take, which is above all, do no harm. The problem is so widespread that 1 in 3 hospitalized patients experiences an adverse event while hospitalized. And in 6% of those cases, the adverse event is severe enough to prolong their hospitalization and send them home with either a permanent or temporary disability. So if we really want to take the best care of patients and avoid harm, it's imperative that we crack open the hood and look within to address the problems and safety issues plaguing us as a healthcare system. In the To Err is Human report from 2014, simulation is actually mentioned 18 times as a tool to help fix these problems. Traditional simulation was the first way that simulation is used to address this. So I'll first describe how traditional simulation set us up to be able to do even more using simulation as a tool. Traditional simulation here at Norton Children's, and in many places, is an immersive, in situ, in the actual setting where we care for patients, simulated patient event, followed by a facilitated team debriefing. It really provides us with a way of optimizing technical expertise and critical thinking and decision-making in a time-sensitive context, as well as training on non-technical skills like communication, enhancing strong leadership and situational awareness, which are really critical in competence in medicine, particularly in pediatrics, where critical events occur a little less commonly. In our debriefings following the simulation, we would first describe what the patient had, discover if we had that right, and then reflect upon what aspects of the case went well and what could have been improved for the next time. As debriefers, we help the team facilitate a deeper discussion of what occurred to solve the puzzles of why things occurred as they did, and help them incorporate any lessons learned into their practice going forward. As such, simulation has become a powerful tool to help modern healthcare professionals achieve higher competence and safer care. Since 2014, we've conducted monthly interprofessional simulations at Norton Children's and soon thereafter at Norton Children's Medical Center. Our groups typically include pediatric emergency medicine faculty, respiratory therapists, nurses, pharmacy, and at times other professionals like child life, technicians, chaplains, parent actors, or even social work. Interprofessional simulations that we conducted in the actual patient care settings with faculty or sometimes fellows not only provided us with an opportunity to reflect on our own performance, behaviors, and interactions, but also helped us really capture something that we were previously unaware of called latent safety threats. In medicine, latent safety threats are significant modifiable threats to patient safety that can materialize at any time and are previously unrecognized by healthcare providers, unit directors, or hospital administrations. This is really things that lie in wait and can hurt a patient at any time. In reference to the Swiss cheese model, latent safety threats can result from challenges with equipment, processes, training, or other system breakdowns, and are typically lying dormant. In the Swiss cheese model, the slices of cheese are the defenses, barriers, and safeguards, and the holes are the failures. Simulation can really be incorporated into every slice of the cheese, expanding the cheese, shrinking the holes, making it safer for our patients. This has become a hot and growing area for research, and studies are showing that latent safety threats can routinely be identified using simulation, and that they do translate to actual changes in care, less patient safety events, and cost savings for the hospitals. So how do we find them? Well, it's best to use the real equipment in the real locations whenever possible. If you're using simulation equipment as a cost savings, then we try to place it in locations where people would actually find it in real life. We like to use an actual code card or a Pyxis and have the participants find the items that they need, and then we give them a simulated replacement to actually draw it up. Our faculty participate in 2 hours of medical simulations per year, and we use 2 physician facilitators and 1 nursing facilitator. Working together on this is really important at helping us capture as many latent safety threats as we can. We like to record the simulations when possible using our Simulation IQ system and or Respond, which is a hardwired video system in our resuscitation bays. In the ED since February of 2020, we've identified 90 latent safety threats in 38 scenarios, which is 2.3 latent safety threats per session. Seen here is a few examples of some of the latent safety threats we've identified. A medication safety threat we found was that an advising nurse was insisting that a newer nurse override IV pump guardrails to force the administration of medication, when in fact they were administering a large overdose. We found cases where there were a 3-fold overdose in vancomycin due to communication breakdown and an absence of an easy reference for medication in the resuscitation room. A failure to prime tubing of a vasoactive medication, which would have led to a 15-minute delay in the patient actually receiving their epinephrine. We found numerous equipment failures. In one example, we had the team moved to use a needle cricothyrotomy kit and actually identified that all of the cricothyrotomy kits were put together with the wrong angiocatheters that would have made performing that procedure safely extremely difficult. We had a simulated resuscitation of a hypothermic arrest and identified that the participants could not locate a low reading rectal temp probe. Despite asking numerous people throughout the emergency department and even nursing leadership, they couldn't identify it, when in fact it was located in our ED Pyxis. Minutes later, an actual hypothermic trauma patient arrived. They immediately were able to locate the rectal temp probe and place it and use it to optimize their care. If you'd like to not only just identify latent safety threats, but also fix them, it's important to collaborate with leadership and have a knowledge of the patient safety events that are occurring where you're working to help guide your simulation efforts. Instead of simply choosing simulation cases on what we feel like learning about or feel like teaching others about, or we think are just really fun to teach, we have to ensure that actual threats of patient harm are considered and baked into the case scenario design. We're currently building the infrastructure within Spark to help us detect and record latent safety threats from all the Spark nodes and feed them back to our divisional leaders to help reduce harm and improve safety. Prompted by a case of a retained guide wire in a patient approximately 1 year ago, we sought to more comprehensively understand the safety threats around central line placement. The physician who performed the procedure had recently done their central line training. So we knew that there was more to the safety issue that needed looking into. We did a full sterile prep and drape ultrasound guided central line simulation that was recorded with our video system and captured 10 latent safety threats, a few of which were that none of the nurses knew that they should be using central line checklist and confirming that there was guide wire removal. We developed a process whereby the physician only receives tegaderm and central line materials once the wire is passed to the nurse. Simulation can actually be used to help transform and transmit a culture of safety. I'm going to use a quick story to convey what I mean by this. In the setting of the COVID-19 pandemic, teams were eager to return to in-person simulation to appropriately prepare ourselves to care for these patients. And there were technical issues to address, such as the donning and doffing of PPE. So we began our simulation scenarios by having participants wear eye shields, a simple surgical mask, and gloves, as they would for all patients relatively early in the pandemic. We asked them to switch out for an N95, capper, or PAPR if performing an aerosolizing procedure. And if they needed to do this in the case, they should stop, go to where they would obtain that PPE, and pick up a sticker, placing it on their clothing. This was done to rehearse that moment where you need to recognize the change for PPE and actually make yourself break to do that. We happened to realize in doing this that the culture in our ER among physicians, but most especially nurses, was that they would start resuscitating in the absence of the right PPE, and they would ask questions later. We thought, well, maybe they're just forgetting to stop because they're so caught up in providing this emergently needed care. But in the debriefing, we realized they said they would do the same thing in real life. They said things like, if I stop to put on the right PPE, I'm afraid it would be seen that I'm not doing a good job. I've done all this training to have this role. How could I make a child in distress wait to receive my help? Like I'm not serving my patients when they need me the most. They worried about reactions from their colleagues if they stopped. This occurred again and again despite the COVID pandemic and absence of vaccinations. But there were also latent safety threats at play, like locations of those materials, which prompted us to restructure where we place them. In debriefing, we empowered the team that it's vital and expected to don the appropriate PPE before providing care, and to speak up and remind others to do the same. We rehearsed these behavioral changes in iterative scenarios until it felt reflexive, and it was reinforced by our divisional and nursing leadership. It was amazing to see that transformation occur on shift. What do we do to improve the quality and efficiency of rare processes? Our mass casualty system needed some updating. Dr. Sperlin and Dr. Cross, in conjunction with many others on the mass casualty team, revamped mass casualty from the top down, and there were many known risk factors like inability to register patients quickly, especially those without a name, physical space limitations, not good strategies for managing the workforce and backup. The first mass casualty sim was a stack of index cards for patients, and this process was rehearsed and reworked until 100 patients per hour could be registered. We then made use of mannequins until we were clear to run our first mass casualty sim on live participants in June of 2021, where 10 COVID vaccinated teenagers volunteered to be our patients in that simulation. It was a really large interprofessional sim with multiple trauma surgeons, ED physicians, nurses, techs, respiratory therapy, radiology, phlebotomy, the lab, blood bank, and OR teams. We recorded it for review and analysis, and it prepared us to receive 32 patients in a bus wreck 2 months later, which arrived in the ED with the ED already full and a full waiting room. Though no one was seriously injured in that wreck, it was really remarkable to see that plan come together and the process improvements we made based on simulations logistically executed. We've worked with Dr. Furlong Dillard and many others in the ECMO team to do something similar to revamp the ECMO process in the ED. We just discussed how to use simulation to improve rare processes, and now we'll hear from Dr. Lanemitz about how to shift the way an entire department does something in a new direction.
Thank you, Dr. Hansen. So when I began my career here in 2011, we were working towards the goal of becoming an accredited level 1 pediatric trauma center, one of the first in the country. Our trauma process, in other words, what we did when a traumatically injured patient arrived to our ED, was highly variable. We had a designated trauma team, and on paper there were specific goals, roles, procedures, but the reality was each time the team responded, something different happened. We had 25 providers who would lead the process, and between them, we had at least 35 different ways of doing things. Our median door to CT time for those needing emergent imaging was 37 minutes. We thus began our journey to standardize the process and cut that time to 20 minutes or less. When we first rolled out the new process, we used the simulation-enhanced lecture approach, where we systematically walked multidisciplinary teams through 1 to 2 cases, focusing on the details of the process itself, the various roles, and their specific responsibilities. Everyone came, nurses, faculty, fellows, and each and every resident that rotated through our emergency department attended one of these sessions each year for the first 2 years. Now, almost a decade after its initial rollout, our process is much more streamlined, and our associated simulation-based education is set up more of a maintenance of skills process. We use a rapid cycle deliberate practice style where we work through the first 15 minutes of a series of 4 cases and do bedside debriefings in the room. Similar to a standard debriefing session, these mini debriefings focus on what went well versus what could have been improved, but they also address how we could have been more efficient and where we deviated from the expected trauma process. These sessions are conducted with multidisciplinary teams of our core nurses and physicians. Our current median door to CT time is 21 minutes. So close. As a brief aside on some terminology, rapid cycle deliberate practice is a teaching technique, something akin to speed drills in sports. When utilizing this style of teaching, you do the same or very similar scenarios over and over, focusing on the details of the process. You can pause frequently for teachable moments, make corrections and adjustments, and then either continue to move forward through the case or start over entirely. If your goal is for the team to achieve mastery learning, you continue to repeat the scenario and the process until the team gets it right. So moving on to a new concept, how can we teach outside of the box decision making in an interactive way using simulation? Traditional teaching and ensuring safe practice is focused on making sure that as few things as possible go wrong. This is a safety one approach. But sometimes in our lives and in this world, that's simply not sufficient to prevent negative outcomes. Equipment fails, tornadoes hit, distractions happen. In light of this, we sought to introduce our residents and fellows to the additional concept of a Safety 2 approach, in which we seek to ensure as many things as possible go right. Safety 2 really focuses on the system's capability to succeed under varying and stressful conditions, on the team members recognizing the need to adapt, and on their ability to make those needed adjustments. For this particular simulation exercise, there were 2 teams of 3 people and 2 Toy Story puzzles. Learners were given exactly 2 written instructions prior to the beginning. 1, complete the 48-piece puzzle as fast as possible, and 2, only a person wearing the blindfold can touch the puzzle or other elements in the room. There were a number of preset difficulties for the teams. The puzzles were lenticular, so the picture shifted depending on how you looked at it. The main room lights were off, and there was a disco ball. There was also very loud and obnoxiously catchy music playing, and 2 of the puzzle pieces were swapped between the tables. Teams discovered through trial and error a variety of ways the unblindfolded members could communicate with their sightless peers. Some groups chose to physically guide their hands. Many quickly learned that using clear terminology was required. Turn it can mean several things when it comes to manipulating puzzle pieces. Later, during debriefing, we discussed how these communication techniques could be used when providing instruction in other settings, particularly when teaching procedures to other physicians. Now, while the teams were not explicitly given a time limit to complete their task, our simulation sessions are generally scheduled for an hour each, and we typically plan for 20 minutes for running the encounter itself and the rest for debriefing and discussion. No team was actually able to complete their puzzle within the 20 minutes. It became clear as the teams worked through this exercise that their ability or willingness to seek adaptations that would ensure the best possible outcome was being constrained not by what the rules said, but rather by what they thought the rules said. They were taking a Safety 1 approach, standard operating procedure, to a Safety 2 problem, unusual circumstances. At the 20-minute mark, the teams were paused and specifically directed to think outside the box, but within the rules. That's when we really saw their inherent human ingenuity that we all possess but often suppress shine through. Blindfolds were removed from the eyes and worn around the wrists. They were cut in half while being worn by one, so they could then be worn by more than one. Lights came on by individuals wearing blindfolds in some manner. Music was turned off, or at least turned down. I did mention they were exceptionally catchy tunes. Once these interventions were implemented, it generally took the teams less than 5 additional minutes to complete their task. I mentioned as part of the puzzle exercise how it helped our learners improve their communication and teaching procedures. But how do we strengthen team closed-loop communication at the bedside? Before we start any of our hour-long simulation sessions, we always review the core principles of crisis resource management with the team. And one of those core principles is closed-loop communication. This is a communication technique involving callbacks of information exchanged between the team leader and team members, and it helps to ensure that what is getting done is what is supposed to get done, and what isn't supposed to happen doesn't. It is, however, an unnatural way to communicate, and too often, both in our real resuscitations and our simulations, we felt it was being neglected. So last year, for our multidisciplinary sims, we decided to push the issue. We took away the leader's sense of sight. The leader could no longer see that what they had ordered had been done. They had to rely on the team to tell them. Moreover, the team members could only tell the leader about tasks that they had both been specifically assigned and completed themselves. This exercise really tested the team's communication skills, but by the end of the exercise, the teams were working and communicating much more smoothly and naturally than when they started. And we've since received feedback from both physician and nursing participants that it has translated to better communication in the resuscitation phase as well. As you may have noticed, we've been using novel simulation techniques to address some unusual educational challenges. Dr. Kopp is now going to discuss some novel ways that we've used simulation to address the especially unique challenges of teaching during the ongoing COVID-19 pandemic.
Thank you, Dr. Lanowitz. So pediatric emergency departments across the United States have seen a significant decline in daily patient volumes, and of course, our emergency department was no exception. So on this graph here, you can see in the pre-pandemic time, we were seeing about 125 to 150 patients per day. And then March of 2020, that time we're all familiar with, we saw a significant decline, and it persisted thereafter. So that left many of us asking, well, how do our trainees acquire and maintain skills and learning during these times of low patient volumes? So in our pediatric ER, we actually have several of our simulation pieces of equipment readily available. So we are there as the physicians, and then we have our trainees there on shift with low patient volumes. So it afforded the perfect opportunity for us to do on-the-fly simulations. So things that we did included walking through our PALS algorithms with a CPR mannequin, practicing high-quality CPR. During this time, we also actually rolled out new defibrillators across our hospital system, which are the Zoll defibrillators seen right there. So this was the perfect opportunity for both our nurses in the ER and our trainees to get hands-on sessions and practice with the defibrillator. And then there in that middle bubble, you can see what is actually called a LifeVac. It is a choking rescue device. We have a simulation baby in the ER that we can give an upper airway obstruction to. So we can practice back blows on that mannequin and then use this LifeVac to help remove the upper airway obstruction. Dr. Hansen had mentioned earlier our simulation efforts towards changing the culture for PPE donning during aerosolizing procedures. One other thing that we rolled out was a plexiglass intubation box, and so we used simulation to practice intubating with this, and it turned out to not really be feasible in clinical care to use this. So we then simulated multiple other ways to reduce aerosolization exposure, one of which was stressing the usage of a HEPA filter in line with our ET tube and vent or bag system. We also have several task trainers available to us in the ER. So you can see photos here of our suture pads, and then also in that bottom right corner, our IO task trainer. So this allows us to, with our trainee, practice suture repair before the actual procedure in the room with the patient. And so we've seen trainees at all different levels still making errors in various stages of the laceration repair. And so this allows us as teachers to coach them through and optimize their performance then in the room with the actual patient. And with the IO task trainer, you can imagine they don't necessarily have the immediate opportunity to then go put one in a patient, but we have had trainees that have graduated and given us feedback that after they went out and placed an IO on a pediatric patient, this training had been critical to their success at that procedure. So much like what Dr. Lanowitz showed us before with introducing the challenges to a task that we're giving our trainees, we now had to ask, well, how do you take the acquisition of those procedural skills and now insert graded challenges that are going to more closely approximate reality to improve mastery? So we have some videos here of our laceration boot camp that we did with our pediatric emergency medicine fellows. And so we started off this session with having them do a laceration repair on a mannequin, and you'll see some of the challenges we inserted. And of course, we had to make this a competition. So it was one team versus the other, and to see who could complete the laceration repair first. So what you kind of got a hint of in those videos is we had one of our fellows actually physically moving the mannequin. We had some noise going in and out in the background with audio of a child crying, and then we had the rest of the fellows acting as other ancillary staff. So starting off the Laceration boot camp with this simulation actually led to a very natural discussion amongst our fellows and questioning of their practices and sharing of techniques. Because this seems like a very common, straightforward procedure, but there are little nuances and differences that each provider will use. So they very naturally started talking about, oh, well, this is actually when I would inject my local anesthetic, this is how I would stabilize my hand, etc. So as facilitators, we had a list of our objectives and things that we wanted to cover with this boot camp. And starting it off with a simulation led to, again, a very natural discussion amongst our fellows covering almost all of those topics. So, of course, we love our in-person sessions, but with the COVID pandemic, we had kind of start and stop times to what we were able to do in person. So this was a great opportunity for us to think of doing things differently than we had been doing them before. So we asked, how can we use virtual simulation and mental rehearsal to improve logistical care of patients? So we had virtual simulations for both residents and fellows throughout the pandemic shutdown. So just to give a couple of examples, with our residents, we talked through several cases of critically ill pediatric patients presenting in various forms of shock. And then with our fellows, we had a unique opportunity to do a simulation where they practiced receiving EMS call-aheads about an ill patient that would be presenting, and then practicing pre-briefing the emergency department team. And this was a great exercise, and sports psychology and performance psychology would tell us that mentally rehearsing is almost as good as actually doing. So this was a great opportunity for our fellows in that scenario. We returned to full in-person simulations for our emergency department team pretty quickly in the pandemic in June of 2020 with a 10-person limit, because our leadership recognized that the simulation is critical to our performance and providing excellent clinical care to patients, and also allows us opportunities to find ways that we can improve care. And then we've also did hybrid simulations with our residents, as you can see in these photos here. So we had our Spark personnel in person with the mannequin and the equipment, while our residents joined us virtually. And so they talked us through what they wanted to know on exam and then what their management decisions were. So we've talked thus far a lot about what we have done within our own institution. And now Dr. Marks is going to talk about what we as Spark are doing out in the community.
Thank you, Dr. Kopp. We just want to take a few minutes to talk about how we can use simulation and what we're doing currently to use simulation to help support our surrounding community hospitals, recognizing that majority of our pediatric patients and newborns are being taken care of in facilities that are outside of our immediate area. So we know that simulation-based medical education in the community is extremely important, and there's a lot of evidence to show that we can improve our patient outcomes in the community by providing this education. When we look at newborns in particular, for newborn emergencies, it's really important and a great skill to help outside centers be able to refine and refresh their resuscitation skills that are probably being used more infrequently, so that they can be comfortable when these neonatal emergencies arise. And we do have a responsibility as the large academic health center in our area to help collaborate, to form relationships with the community hospitals and share our expertise and provide them an environment where we can practice and provide feedback. And this is what we are trying to do with our neonatal outreach team. It's a really fun team, and we have a goal to improve our outcomes for critically ill newborns in the community. And what we do with the outreach team is that we provide on-site simulation at different places around the state. It's an interprofessional group that goes out. We have physicians, we have neonatal nurse practitioners, we have nursing, our neonatal nursing educators. And we also work with our Just for Kids transport team. And sometimes we will do these outreaches together, and the transport team does do some outreaches on their own as well, so they're very active in the community. And when we go out, we provide several things. We usually start with some sort of delivery room simulation, and then we can keep that going and extend that case or scenario into a critically ill newborn. And some examples that we will do are seizures, or hypoxic ischemic encephalopathy, or congenital heart disease, and stabilizing those critical ill patients. It's important for us before we get to the site that we do a pre-session assessment of their needs. And so we will have a meeting or communication with the center about what they're needing, and then we provide a customized education session to help meet those needs. And we can do that through several scenarios. We can do skill stations. We might do multiple sessions in one day. The groups can be large or small, and that really looks different every time we go out. It's really fun to do this, and we meet a lot of people. We work with labor and delivery units. We may have obstetricians or pediatricians or emergency room physicians. We'll have nurses, respiratory therapists. We have support staff. We have everybody who's participating in this to help keep these skills fresh. Once the session is over, we do debrief with the teams and provide feedback, and we do that in several ways. Sometimes we will provide ongoing feedback during the scenario as we get through things, and we'll correct or provide help during the scenario. If it's a team that's very comfortable with what they're doing, we might wait and provide that feedback after the scenario is ended. But we will do that kind of based on what the needs are at that moment. And through this process, we do identify several latent safety threats that come up, and it's really interesting to see that oftentimes it's not really us that's coming up with these safety threats. It's the team itself that's recognizing things as we go through, and we can help facilitate improvements in that area. So we do meet with the leadership of the teams before we leave or soon after the sessions are over, and we will go through these, and it's really cool to see what the team comes up with. And a lot of times it has to do with equipment or logistics, or we might identify some needs for some ongoing training, and then we can schedule sessions to come back and provide that if needed. Right now we try to go out monthly, so we try to keep at least one day open every month for these outreach sessions, and any hospital that we can get to can schedule with us. And so the key leaders on this team would be Leanna Magna, April Sargent, who are our neonatal nursing educators, myself, and Dr. Shusky, who are the lead neonatal physicians for the outreach team. So if anybody has any interest or needs us, feel free to contact us with that. But when we're another way we can use simulation in the community is when we are developing new facilities or maybe upgrading the facilities in themselves. For one example where we used simulation in the neonatal community was when we were transitioning and building our level 2 NICU at Clark Memorial. We have used simulation there to help identify some of the logistic things as we are taking care of more critically ill infants in that area. But it is important because it does help you point out spaces and potentials for safety threats. Where are you going to put your equipment? What does the space look like? What does the setup look like? Going through these different scenarios will help you be able to really pick those things up and to examine the process, and then work towards better outcomes. So it is it's an important area where we can use simulation when we're growing, and which we know that we are, and any center that's kind of redoing things or providing a new environment for the patients, simulation can become extremely important in that sense. Now I'm going to hand it over to Dr. Calhoun, who's going to talk to us about the future of simulation in healthcare.
Morning, everybody, and thank you again for this chance to talk and share some of the vision of the SPARK program, as well as some of our current activities. I'd like to step back for a moment, though, and take a look at the field as a whole. Where is simulation as a whole going? This is still a rather young field in the grand scheme of things, only about 20, 30 years old in terms of its inception to its current development. And as we all know, and from previous talks we've given, the pandemic has placed a number of large-scale stressors on how we do our work. And so the question of where we're going really is very important. What can we expect from simulation in the future? What are the national organizations that are involved in this field doing to promote things? And so I'd like to focus on three areas that hopefully will become very clear as we go through as to why they're important and as to why these are the way that the field needs to move. And so given the evolution the field's experiencing, I think it's fair to say that the future of simulation, number one, is hybrid between virtual, augmented reality, screen-based, and live courses. The future of simulation is evidence-based. Ideally, everything we do is evidence-based, but I'll get into exactly what this means in a moment because we're trying to up the ante, so to speak, on that within the Society for Simulation in Healthcare. And finally, the future of simulation is diverse, equitable, and inclusive. So the future of simulation is hybrid. Again, the pandemic has not ended as quickly as we might have hoped. I think we all still hope that eventually this resolves, and I believe that it will, but it is going to be a bit more of a gradual wind down at the very least. And so the innovations in virtual and telesimulation, those words are actually used relatively interchangeably. We don't have a clear nomenclature yet, as I spoke about last year, that were initially born of necessity and just the sheer willpower of the science simulation to stay alive in a difficult time, have now become well established as modalities of teaching. And really, the vision that we have gained within the field is that each of these different ways of accomplishing what we're doing has its own use, has its own purpose. In the earlier days of the field of simulation, there was a lot of focus on the idea of fidelity, this idea that replication of the clinical environment in greater and greater detail was the way to go. And like everything else in medicine, the answer that we've learned is, well, it depends. There are some things that a kind of robust online system with a lot of discussion, sharing of videos, and physiologic information can really do to enhance certain points. Thinking sort of the cognitive decision-making around certain medical care. On the other hand, if you are dealing with communication simulation, where you really need to create that emotional environment, then higher levels of environmental fidelity are needed. And so right now, we are actively working within the simulation community to generate the needed knowledge to know what is right and when is it right. What do we need to do to determine what type of virtual simulation, what type of telesimulation, or what type of live is best for the educational objectives that we have before us. And so just to introduce you to a new group that's formed over the past couple of years, the Healthcare Distance Simulation Collaborative has identified ongoing working groups that are looking at needs identified during an initial simulation summit for virtual simulation conducted in 2020, right after the pandemic started. And these groups are focused on some very interesting things. Number one is the creation of a pictographic language to describe virtual and telesimulation, and establishing a common verbal nomenclature for this. You might wonder why this is important when we have all these words already, and the answer comes down to research. It's very important that we have specific words for specific things. Otherwise, how do we know what we're studying, and how do we know that when somebody goes to implement one of these types of simulation, they're doing it in a consistent fashion? And so there's some very important work going on in figuring out exactly what we mean by these terms and what we should mean moving forward. There's also a research agenda that is forming around this, looking at some important areas such as psychological safety. What does it mean to be psychologically safe in a virtual environment? Again, you might wonder what that means. Aren't you more distant? Isn't this a little less immersive? And the answer is yes, but just consider this. Whenever you are teaching on Zoom, you actually have unprecedented access to the room or the house or the teaching location of the person you are teaching. And in some of our discussion groups around this, people have commented on things they have seen in the room behind them and how that may have inadvertently changed their perceptions of the learners. So this is a very active area that needs consideration. How do we avoid being biased by these things? How do we create environments that feel safe for the learners, that feel safe for the educators to really explore what's going on? Outcomes. How does one assess the outcome after a virtual simulation? Again, an open area for exploration. And then finally, simulation is often used as a means of assessing learner skill, learner attitude, learner knowledge. But how does one do this when one's not physically present? Oftentimes, simulation-based assessments would involve watching people performing specific tasks on the mannequin, and many of the assessment tools have been validated in that context. What does it mean to assess in a virtual environment? There have not been many, if at all, any tools validated for use. And so these are open and wide open areas. If anybody in the department is interested in exploring these, please let me know. Next, the future of simulation is evidence-based. So like most fields, the early days of simulation, even prior to the pandemic, were a time of unrestricted innovation. People would develop new ideas, they would write about them later, and implement them and develop new ways of accomplishing this. Some of the first simulators were built in people's garages or basements out of spare parts in an attempt to get the field going and to establish how we accomplish this. But the field has grown and matured since then. There is significant research out there. There is significant educational theory describing why what we do is important and how it actually affects our learners. And so much has been done now to formalize training and practice, including the development of simulation fellowships for trainees interested in pursuing a career in simulation. This is relatively new. The developing of standards and accreditation from the Society for Simulation Healthcare, and the development of evidence-based guidelines. And so we are currently involved in a large-scale systematic review process aimed to end in 2023 at our research summit, focused on the following areas. And our hope here is to provide high-quality, evidence-based guidelines similar to those provided by the American Heart Association or other professional associations regarding the state of the literature in mastery learning, deliberate practice, feedback, spaced learning, self-guided learning, team training, in situ simulation, virtual reality, all of these areas, standardized patients. Each one is being looked at separately with finely honed PICO research questions and large-scale standardized reviews. I can report on the one that I'm working on as well. We have about 11,000 articles to screen. So if any of you in the team are in the screening phase, let's make the final push. And we aim to present this information in 2023 at the SSH Research Summit, Beyond Our Boundaries. This is actually the sign for the 2017 Research Summit, which is the last one we had. I don't have one for the new one yet, but it'll be something similar. And the goal after this is to create a set of evidence-based international guidelines based on the literature agreed on by experts that can be used to guide educational and research practice in the field. And finally, the last several years have taught us the need for a deliberate focus on the mitigation of bias and on ensuring that diverse, equitable, and inclusive care and education is given to all. And so because of this rising consciousness in our healthcare communities, the Society for Simulation Healthcare has also initiated ongoing task forces to create curricula addressing DEI issues, and also to create more diversity, equity, and inclusion within the simulation community itself. In addition to this, the International Network for Pediatric Innovation, Research, and Education crowdfunded actually several research awards that were given out this year specifically focused on using simulation to address DEI issues. And so this is an area of ongoing work, and one that I am hopeful will transform our field and transform the way that we deliver healthcare education. As a final shout out, I would just like to identify the members of the SPARC team. I won't read all the names, there's a lot from there, but please take a look and please recognize these individuals for their service to simulation at Norton Children's Hospital and throughout the Norton healthcare system, and for the University of Louisville Department of Pediatrics. Finally, I'd like to thank each of you. We'd like to thank the Norton Children's Hospital Foundation and Norton Children's Hospital leadership for help in funding the acquisition of an additional mannequin that we are currently rolling out. It should really up what we are able to do in terms of at least mannequin fidelity, which, although fidelity isn't everything, it is quite important in certain areas, and this mannequin will assist us in doing that. So thank you. If those of you that assisted us in gaining this funding are online, we really appreciate it. I'd like to open it now finally for comments or questions, and hope that you have enjoyed this tour of new simulation activities in the state of the field. So I'll add to, we do have a few minutes, and so if anyone is interested in placing questions online, oh, excellent, there, we got one from Sarah. Very impressed with the photography. I was as well. These are not slides I can easily make at all, and I think this team is great for this. I got to learn from them how to do that myself.
That was with help from the Gram, your filters and whatnot. But yeah, really, I mean, those are all from simulated activities that we've done here and around the hospital. And you can see what amazing groups of people are willing to get together at, difficult times of day when they're tired and when they've been through a lot, they still show up because they understand the value of it. So thank you so much to everybody who's given so much to do this.
You want to get that one? Sorry.
Dr. Mulcher asks, what are your thoughts on gaming software, things like Oculus, Google Glass, or on the future of simulation? Aaron can't wait to jump in on this.
So the answer is, my thoughts is that it is an absolute necessity, and I know many people that are moving forward to make this a reality. One thing that I personally think is that while a lot of effort is being rightly focused on full virtual reality, my personal bias, this is just my personal opinion, is that a more augmented reality approach might be better. I have seen AR systems that enable you to project objects into a real physical space. I have seen AR systems that allow you to project virtual family members and people into a real physical space so that you can actually call up non-player characters, if you will, in the middle of a simulation that has real players. It's fascinating. Other systems that I know are being worked on would enable you to actually see inside the mannequin. If you, say, give a dose of epinephrine, you could actually watch the blood vessels constrict, watch the heart rate change. And this is what I was really getting at earlier when I talked about fidelity not necessarily being all it's cracked up to be. There's no real fidelity in placing an image of the heart inside a patient. You can't see that in real life. And so in a sense, it's hyper real because it lets you see things that you never would. But it might really help you meet your learning objectives if you're trying to understand cardiac physiology and the use of epinephrine to resuscitate. So just as one example there, it shows how we can move beyond the concept of fidelity into what is needed to achieve our goals.
Yeah, I was recently at a simulation conference and just seeing some of the more recent work being done, like projecting a hologram of a patient that people are able to interact with to take histories and things like that. It's very Star Trek-y. There was a question, I saw a national presentation incorporating social justice and healthcare inequities in simulation. Do you have plans to expand further into this space? Thank you, Dr. Kim, for that question. I would say absolutely. I feel like we just started sort of dipping our foot in the water. We recently, in November, did a simulation looking at cognitive biases that was done by one of our fellows, Dr. Estep, and we incorporated an element of language barrier where the parent actor was fluent in Spanish and the team had to use an actual interpreter to communicate with the parent. And then we debriefed the dynamics of that. There's so much more work that could be done, and if that's an interest of yours, please get in touch with us so we can support that important work.
I would also add in that we have been supporting this work on a national level as well. Many of us are involved in Inspire, and it was actually members of our team that assisted both in developing and crowdfunding the grant that I mentioned. Yeah. And we are also involved in SSH's current push to basically create a long-standing monitoring system within the simulation community that helps us see where these needs are as they arise and incorporate these into the work, not just of our own center here, but really worldwide simulation. So we're really helping push the limits in those areas.
Dr. Boland asked about what options are there for helping using gaming or avatar-like sessions to be able to provide more simulations, as there is the limiting step in being able to deliver them based on the number of people and amount of time you can use. I've been thinking about that so much that medical education could really adopt that and really blow the lid off of how much simulation you could harness for your objectives. We are reaching the end of our time here, and I appreciate all of your questions and interests. If you guys think of other questions you have, please get in touch with us. We really enjoyed sharing this information with you today. Happy Friday.
Thank you.
Nice job.